Dear network, we want to welcome you to this afternoon session, and we continue with the COVID series. As you may be aware, we are currently experiencing the fourth wave, and something very interesting about this wave, it has had also affected the children, and we felt it's necessary to share this important presentation on children so that we may just have some important knowledge and information around how to care. So in the hub, I am joined by Dr. Rose Chidohia. She is a registrar in pediatrics, and she is been working on the COVID ward here at Children's Hospital. And today she will be presenting our case for this afternoon. And I also am privileged to have Dr. Kalima Nawa, a pediatrician, who will be presenting our main didactic session today and talking about childhood COVID in children. So we also have a privilege to have on the call experts on the field. We will have Professor Mpapalwani, hopefully he will be able to join us. Then we'll have Dr. Kabala, we'll have Dr. Matthew, Dr. Manechanya, Dr. Chelo Mwinga, Senior Registrar currently overseeing the COVID ward. And also we have Dr. Natasha Ngwenya, also from Levi Manawasa, consultant attending to pediatric COVID there as well. So we actually have a very experienced panel who will try and discuss our topic. And my name is Koze Jambo, will be your facilitator for the afternoon. So we want to encourage the network to feel very free to participate, to ask, to send your questions in the chat, and then we'll be able to respond to them as we go on. And if you have any questions, you raise your hand using the reaction or the annotations on the Zoom, and then we'll be able to get back to you. So we'll have our first session being presented by Dr. Kalima Nawa, and then after that, we'll have a case presentation. So without further ado, we'll invite Dr. Nawa to just introduce himself and share the slides and begin the presentation. Dr. Nawa.
Good afternoon, everyone. I'm Dr. Nawa Kalima, a pediatrician and also who's worked at Children's Hospital as well as National Heart Hospital. I will be the deductive presenter for today, and I'll be taking you through most of the presentation for today. Let me just share my slides. Are they visible?
Yes, Dr. Nawa, we can see them. Perhaps you could just go to display and swap display. We're seeing presenter mode.
Oh, okay. All right. Let me just do this. Sorry, just a second. Can you see them now? Hello, Echo Hub?
Yes, we can see them.
Okay, all right, thanks. Okay, good morning once again. So our four main objectives today to discuss the epidemiology of COVID-19 in children in light of the new variants, to describe the common clinical presentation of children with COVID and discuss the management of COVID in children. as well as discuss COVID vaccines for children. Before I can take you through that, there are a couple of questions.
All right, thanks. I think we'll just do a poll question so that we can allow the participants to also take part. We've shared the poll questions, and I hope we can see them. So we would like to, which of the following is correct regarding the current wave of COVID among children? There is equal sex distribution, A. B, up to 17% of positive cases in some countries have been noted. C, actual incidence in children is similar to adults. D, in Africa, there exist gaps in data and testing among children. Then E, we have all of the above. So we encourage the network to participate. Please go ahead and poll and pick a poll which one you think is the correct answer. We're saying which of the following is correct regarding the current wave of COVID-19 among children. A, there's equal sex distribution. B, up to 17% of positive cases in some countries were among children. Actual incidence in children similar to adults, but children are less exposed to testing. In Africa, there exist gaps in data and testing among children. E, all of the above. So we'll just give the networks another 20 minutes, sorry, 20 seconds before we can end the poll. So far, there seems to be an option that people have picked all of them, but most of them think E is the correct answer. Okay, allow me to end the poll now. I will just share the results for us to see how the distribution has been. So you can see most of them think E is the correct, some think D is correct. Have others think the others. So as we go on, we will be able to share what is correct. Dr. Nawa, you can pick it up.
Okay, thank you. So COVID in children affects all age groups and has equal sex distribution. Up to 17% of positive cases in some countries were actually among children. And the actual incidence in children is similar to adults, but children are less exposed to testing. This may be due to health-seeking behavior, as well as most children tended to have milder symptoms, and so were less likely to be taken to the health facilities. And then some parents are just in protect mode ever since COVID started. In Africa, there exists a gap in data and testing among children. So COVID once again joins the many other diseases for which we have gaps. And then most children get infected in the households from adults. With each new variant, there's been an increase in the number of children presenting with COVID. There's still not enough data yet to give exactly how many children have been affected in more recent variants, but we do know that there's been increase in cases among children, and Omicron is yet to, we're yet to get data from the Omicron variant in terms of distribution among children. I must say that we expect that with every new variant, if the infectivity rate is high, the expectation then is that more and more of the population will be testing positive, and that includes children. I'm sure we're quite familiar with a lot of these definitions, but just remind everyone that we do have what we call a suspected case, and these are usually a child with an acute respiratory infection, who, especially in a case where we have high prevalence, has at least one or more of the signs of acute respiratory illness. or has had contact with somebody with confirmed or probable COVID, or has severe acute respiratory infection, which can otherwise not be explained by any other condition. And then a probable case is one that is suspected case with an inconclusive result, or for one in whom we cannot make a confirmed test because of a lack of testing. And then, of course, we know that we confirm cases nowadays either with PCR or with rapid tests. And then we do have what we call a contact. Most of us are quite familiar nowadays with what we call a contact. And this is one who's been exposed to a person within 2 to 14 days of the onset of symptoms of a probable or confirmed case. And usually this is an intimate contact. So usually within 1 meter, and there may be direct physical contact. And in our children, usually we are talking about caregivers as well as siblings. The common clinical presentation of COVID in children. We'll have another poll question here, and then I'll take it up after that.
Thank you so much. So far, so good. We're learning a few things. So the next poll question is saying, regarding the clinical presentation of COVID-19 in children, which one of the following is not correct? Majority of children have asymptomatic illness. An equally large number have mild to moderate symptoms. 7% have severe illness requiring ICU care compared to as much as 53% of adults. Then D, multi-system inflammatory syndrome is a common presentation in children. Which one of the following is not correct? You can hear the emphasis there. Majority of children have asymptomatic illness. An equally large number have mild to moderate symptoms. 7% have severe illness requiring ICU care compared to as many as 53% in the adult population. Multisystemic inflammatory syndrome is a common presentation in children. Which one is not correct? So we have 30 seconds before I can end that poll, and so far so good. We still invite more people to participate in this poll. So far only about 47% have participated. So we're expecting at least we need to hit the 50% mark. Okay, there we go. Let's we've hit the 50% mark. A few more seconds remaining. Very, very interesting distribution. I'll end the poll and share the results. You can see, Dr. Kalima, that we have quite a range of choices here. 17% think it's A, another 17% think it's C. So I guess there's a lot for us to discuss as we go on. Please pick it up.
Okay, thank you. So majority of children have asymptomatic illness. An equally large number have mild to moderate symptoms. This is data from a number of systematic reviews from the recent waves that we've had. 7% have severe illness requiring ICU care compared to as many as 53% in adults in some populations. So this once again does give us some hope that children are less likely to have severe illness. However, a concerning presentation is multi-systemic inflammatory syndrome in children, which will elaborate some more as we go along. So there's currently no published data in settings with high malnutrition and under 5 mortality. I guess it's left to us now to generate this data or to record this data and then give our own statistics. The clinical course in children, you will get children with respiratory distress symptoms. These include increased work of breathing, recessions, nasal flaring, and then you do get patients with dehydration, usually due to increase in sensible losses. I apologize, this slide is supposed to come after the next slide, but this is simply describing a picture of severe pneumonia. But in short, the clinical syndromes in COVID-19 will either be uncomplicated illness, a mild pneumonia, a severe pneumonia, which is described in adolescents as respiratory rate greater than 30, severe respiratory distress, and saturations less than 90% in room air, with a fever or suspected respiratory infection. And then for younger children, you have a cough or difficulty breathing with central cyanosis. There may also be age-specific tachypnea, saturations less than 90%, and severe respiratory distress. Most of these are clinical diagnoses that we are all able to make in terms of severe pneumonia. A syndrome that may result is acute respiratory distress syndrome. In this case, you have new or worsening respiratory symptoms within 1 week of non-clinical insult, and chest imaging consistent with ARDS. Respiratory failure not explained by cardiac failure or fluid overload. And then other syndromes that you may see are sepsis and septic shock, which we should all be able to make a diagnosis of. So in terms of management of children, first of all, in terms of our testing, we have molecular testing, as well as rapid diagnostic testing, which uses antigen tests to determine whether a patient is positive or negative. In terms of isolation criteria for suspected or confirmed cases, I think we're quite versed with this nowadays. We know that a well-stable patient will require home isolation. An unwell patient with a well parent can also be isolated from home if they have mild symptoms. But if they have severe symptoms, they can be isolated in an inpatient facility. A patient who is otherwise well or is suspected to have COVID but is well, but as an unwell parent, can be isolated from home, and an alternative caregiver can be provided. I must say there is a caveat to this, because some of our pediatric patients are breastfeeding patients. So some of these have to be taken on a case-to-case basis. So initial tests to order at admission include a full blood count, a serum biochemistry, CRP, ESR, D-dimers, ferritin, interleukin-6, procalcitonin, then chest X-ray, plus minus CT scan if available. The classic picture that we see in COVID, small irregular lung opacities, interstitial alterations, usually affecting peripheral areas in initial phases. And there's the common ground glass opacities that you also see. There's also features of consolidation in severe cases and pleural effusions, though these are uncommon. This is just CT images showing ground glass opacity, segmental consolidation in both lungs in a child with severe infection. So in therapeutic management of children with confirmed COVID, we have 4 main guiding principles, which is early identification. In this case, we are talking about identification of a suspected case or probable case, early isolation of such patients, and making an early diagnosis, and then instituting early treatment. So management requires that there's quick identification of patients needing hospital care, And then supportive care has to be provided for all pediatric patients. Most children with COVID-19 improve with supportive care, even with severe disease. So mild to moderate cases, usually your focus here is to relieve symptoms. We aim to control fevers and body pains with paracetamol. Antihistamines, particularly non-sedating antihistamines, are helpful with reducing nasal congestion. Children with non-severe COVID may require hospital admission if they are at risk of severe disease due to underlying conditions, such as immune compromise and comorbidities. Of note is we're talking about comorbidities like renal disease, congenital and acquired heart disease, and as well as some patients with HIV. However, decisions to admit patients who are otherwise stable, but in the risk group, will still be done on a case-by-case basis. Then, of course, febrile neonates and infants would have to be admitted, even when they are non-severe. This is just simply showing the oxygen delivery methods that we have. And of course, O2 escalation guidelines now exist in our Zambian guidelines. In essence, we need to remember that children in different ages do not all receive the same amount of oxygen, but there is need to escalate oxygen according to the oxygen demands and available delivery devices. Of course, the common devices are nasal cannula, appropriately sized, but we also have masks, rebreather and non-rebreather masks, venturi devices. Facilities that are able to institute CPAP can start CPAP if patients are not saturating well on nasal cannulas. But if you have other modes of delivery, please do go ahead and use those. So provision of the respiratory support is, of course, supplemental oxygen, continuous positive air pressure. Of course, we have non-rebreather masks and then mechanical ventilatory support. In most of our cases, or most of our children, we opt to provide O2 therapy without having to reach mechanical ventilation. And most of our children tend to respond quite well. Provision of feeds and fluids and electrolytes is important in these patients, so it's need to insert non-nasogastric tubes, as well as ensure that these patients are well hydrated. The use of empiric antibiotics is indicated for a patient with suspected community-acquired pneumonia, and the appropriate antibiotics should be given. There is no longer a role for combination therapies that include macrolides and penicillins, as data has already shown that there is no role for macrolides unless there is suspected or confirmed co-infection with atypical organisms. There's also important to monitor for a cytokine storm. So in our setting, we'll be monitoring blood pressure, oxygen saturation for worsening hypoxia, and then observing immune indicators such as CRP, D-dimers, ferritin, interleukin-6. Where possible, monitoring these 2 to 3 times a week may show worsening or improving disease. Antiviral therapy, there's still a lot of data that needs to be collected on this. There's still trials ongoing, but currently antiviral therapy has been restricted for severe cases of COVID-19 in children, particularly in at-risk COVID populations. And of course, these will have to be made on a case-to-case basis. Glucocorticoids are also reserved for severe illness or those patients requiring ventilation. Doses are as indicated there. So prophylaxis or therapeutic anticoagulation should be considered, particularly in patients with raised D-dimers. And an algorithm exists that may help with making a diagnosis of whether to give thromboprophylaxis. So in a patient with COVID-19 or MIS-C, who is ambulatory or asymptomatic, there's no need for thromboprophylaxis. Whereas those requiring ICU care or requiring moderate supplemental oxygen with raised D dimers all need some sort of thromboprophylaxis. So a mention on multisystemic inflammatory syndrome in children. This is I like to call it the mimic because it tends to mimic a number of immune dysregulation syndromes, such as Kawasaki, toxic shock syndrome. There have also been similarities with macrophage activation syndrome and the cytokine release syndrome. Most patients have a negative COVID test, but positive serology for COVID. And most MIS-C cases have occurred in older children and adolescents who were previously healthy. So this is one of the things that most of these patients may have been previously healthy or may only have shown mild symptoms. And yet they tend to develop this severe complication of COVID. Another thing to mention is that this is a very rare complication. Its onset is often 2 to 6 weeks after documented or suspected COVID. The challenge we have is that this may still develop in a patient who was otherwise asymptomatic. And we know that most of our pediatric patients are symptomatic, and those who are symptomatic in our current situation may not go to the hospital. As you may know, our testing is currently restricted to health facilities. And so we may only be seeing these patients when they present, and we may have a diagnostic conundrum as to what we are dealing with. It just serves to remind us to always do, if we get a COVID negative test and we see suspect MIS-C, let's always make sure we try and do a serology test. Maybe we may be able to find something there. So the presenting symptoms, almost every patient presents with a fever, and this is usually persistent. There may also be gastrointestinal symptoms with abdominal pain, vomiting, and diarrhea. Rashes are quite common, conjunctivitis. There's also mucomembranous involvement, where you have red or swollen lips, a strawberry tongue, neurocognitive symptoms, respiratory symptoms. So unlike COVID, patients with MIS-C develop respiratory symptoms mostly due to heart failure or fluid overload, and rather than due to actual respiratory involvement. There are two criteria that exist for making diagnosis. There's a CDC definition of MIS-C, case definition, and then there's also a WHO case definition. And we can obviously see the differences here are mostly in terms of the age, the duration of the fever, and then clinical findings. Particularly in our setting, we tend to restrict ourselves to WHO classification of rash, conjunctivitis, or mucocutaneous signs, hypotension or shock, cardiac involvement, coagulopathy, and acute GI problems, and the evidence of prior COVID infection or likely contact with COVID-19 patients. And then you get elevated markers of inflammation such as ESR, CRP, or procalcitonin, and no other obvious microbial cause of the inflammation, particularly staph or strep infections, which may give you similar pictures. Of note is that even with all these criteria, what you may get are clinical symptoms, and you may not be able to get any evidence of COVID-19 infection. So in a situation where we have high prevalence, the index of suspicion should still be high even when we get a negative serology or negative COVID test. So in MIS-C, most of the features include shock, or some of the serious features that we are concerned with include shock. Mucocutaneous findings do tend to point more to a Kawasaki-like picture. They may meet a complete Kawasaki criteria in 22 to 64% of the patients. Myocardial dysfunction is one of our major concerns. In these patients, you want to look out for evidence of coronary artery dilatation or aneurysms, as well as possible myocarditis. As I mentioned, acute respiratory failure may occur and may require non-invasive or invasive ventilation. AKI is another common complication, and serositis with pleural and pericardial effusions, as well as ascites, hepatitis, hepatomegaly may also occur. And then neurologic manifestations are the least common, accounting for about 6 to 7% of current case series that have been reviewed. So the management of MIS-C is inpatient, particularly in our setting. Outpatient care is only in those in whom MIS-C diagnosis is uncertain and have mild symptoms. Supportive care, depending on systemic involvement, is important. So here there's need for a multidisciplinary approach. As you can see, the variety of systems that can be affected. Therapy includes, but is not limited to, intravenous immunoglobulins, mostly in combination with corticosteroids, as evidence or current practice has shown good results when the two are combined. Immune modulators, which are maybe prescribed on a case-by-case basis, and these mostly target or are meant to inhibit tumor necrosis factor, interleukin-6, and interleukin-1. There's also a role for aspirin, initially because of its perceived role in Kawasaki disease, but has found use as well in this syndrome. And then there's a role for antithrombolytics. I will now discuss COVID vaccination in children. So why vaccinate children? We know that children can still get severe disease and can be hospitalized. Of note is that they are still at risk of developing MIS-C. They can develop both short-term and long-term complications, and children are known to be spreaders of COVID-19, both at home and in school. We are also a resource-limited country. It's important that we are in control of the pandemic in our country. Vaccination and vaccination of as many people as possible can help us reduce the spread of infection and also reduce the likelihood of severe infections. So as I mentioned, reduce transmission is one of the things that vaccines help. Reduce spread, protects the community by reducing the spread. This is what you may be termed as herd immunity. And there's less disruption to school attendance. Now, of note, one of the things that we need to remember about the COVID virus or COVID variants is that it's a virus that doesn't really proofread its DNA. And so its genetic material, if it does mutate, tends to continue to mutate and spread among different individuals without being proofread or removed. In a normal being, when there are mistakes in the DNA, those cells with the mistakes are chucked out. And so we don't get to see these mutations. But because this virus cannot even do that, it tends to replicate and produce more and more variations in its DNA. Most of the variations are small and do not warrant the name of a new variant. But when they're a significant number, they are termed a new variant. These variants mean that the infection spread may be more. And the vice versa, or the vicious cycle is such that with more spread of the virus, there is risk of even more variants being produced. So it is important that we vaccinate and practice infection prevention measures so as to reduce the amount of active virus in our community and hopefully completely eliminate new variants and new infections. So majority of the vaccines in the initial phases were only approved for adults and adolescents aged 18 and above. However, there's been emergency use authorization of mRNA vaccines from the age of 12 to 17 years. In particular, the Pfizer vaccine has been used in the United States and in Europe to vaccinate this age group. However, research continues on this front with more evidence showing safety in younger populations, more emergency use authorization has continued to come in for younger populations. And the goal to generate vaccines in younger populations continues even in countries like China. So why vaccinate these children 12 to 16 years of age? So in the United States, children 5 to 11 years still accounted for a huge number of patients presenting with COVID and accounted for 1.7% of all deaths among children. We do know that in terms of presentation and severity, even the much younger age groups can be at increased risk of mortality. They may not exactly fall in the group that can be vaccinated, but protecting them by cocooning them and vaccinating every other family member actually does reduce their risk of getting infection. Now, the indirect impacts of COVID-19 on the COVID-19 pandemic include worsening of mental and emotional health, widening of existing education gaps, as we've seen in our country in terms of our school performances, decreased physical activity, as most people have tended to stay at home in order to isolate. And this, of course, it promotes obesity, decreased healthcare utilization, decreased routine immunizations. So patients fear to go to the hospital when there are surges in COVID-19 measures. The lockdowns also haven't helped. And so vaccination rates for other conditions as well as for COVID may be lower. Increase in adverse childhood experiences, and there's loss of caregivers. So in terms of the public health problem, an example of the US shows that children are at risk of severe illness from COVID-19, with over 1.9 million COVID cases and over 8,300 hospitalizations. Cumulative hospitalization rate similar to influenza season. There's still a risk of MIS-C syndrome in children, most frequent among children 5 to 11 years of age. And there are still other post-COVID conditions that have been seen in children, including myocarditis. COVID-19 in children leads to missed school for themselves and their communities. The wide use of an effective vaccine would reduce public health burden of COVID-19 in children 5 to 11 years of age. Several lockdowns have led to loss of several hours of education. South Korea vaccinated 78.8% of its population and 12.8% in the 12 to 16, in the age group 12 to 16 years of age. And this has resulted in fully open schools in these countries. Of course, we saw something similar in Europe, where a lot of activities tended to return to normal. But I think one of the things that we're missing is that we still need to practice infection prevention measures. So are vaccines safe for children? So a phase 2 to 3 trial of mRNA vaccines has shown efficacy with similar or higher compared to adults, particularly in adolescents. We do know that there is a very, very rare sign or a very rare complication of myocarditis or pericarditis reported for mRNA vaccines, but these numbers are less than 1%. And available data suggests that these cases of myocarditis and pericarditis are mild and cannot be compared to actual myocarditis seen in COVID-19. In October 2021, the Global Advisory Committee on Vaccine Safety concluded that in all age groups, the benefits of mRNA vaccines in reducing hospitalizations and deaths due to COVID outweigh the risks. In November 2021, one stringent regulatory authority approved the mRNA vaccine BNT162b2 for use in children 5 to 11 years. And then trials, like I mentioned earlier, of 2 inactivated vaccines such as Sinovac and BBI-BP-CoV have been approved for use in China in children 3 to 17 years of age, but these are yet to get emergency use licenses from WHO. So in terms of benefits of these vaccines, particularly the Pfizer-BioNTech vaccine, the benefits have to be weighed against the risks. We know that the benefits are prevention of cases, prevention of severe complications, reduced transmission, and probably allowing for safer return to school and social interactions. But however, the risks are that there's the risk of myocarditis and other rare events. I must mention that most side effects of these vaccines are local side effects. The common ones that we've all experienced, such as pain at the injection site and some slight hyperemia there. There's also a short-term reactogenicity, which means has been on everyone's mind in terms of how long do these vaccines actually protect one, particularly with new variants. So I've mentioned some of the side effects here: pain at short sight, headache, chills, muscle pain, fever, joint pain, swollen lymph nodes, pericarditis and myocarditis. So in cases where you have suspecting or confirmed pericarditis or myocarditis, it's important that we're monitoring such patients. Patients are initially, most of these cases were initially observed in adolescents and young adults after a second dose. And the symptoms were chest pain, shortness of breath, palpitations, an important symptom to remember because most of them were complaining of palpitations. And these responded well to treatment and quickly resumed normal life. Due to mild and short nature, and given the rarity of occurrence, WHO and CDC gave the go-ahead to continue to vaccinate. So what is WHO saying? Countries should consider the individual and population benefits of immunizing children and adolescents in the specific epidemiological and social context in developing the COVID-19 immunization policies and programs. As children and adolescents tend to have milder disease compared to adults, unless they're in a group at high risk of severe COVID, it is less urgent to vaccinate them than older people, those with chronic health problems and health workers. What this simply means is that which we already do nowadays, which is we vaccinate the patients most at risk and most exposed, followed by the general population. And we must say that evidence concerning the second statement continues to evolve because with newer variants, we are seeing more and more infections in younger groups. And we may vaccinate all the other population, but with a high R naught or high reproductive rate for the new variants, we may only achieve herd immunity by vaccinating everyone in our population. So in summary, the key take-home messages are: there's increasingly more data on COVID-19 in children, but there remain gaps in sub-Saharan Africa. COVID affects all age groups with increasing numbers, with newer variants and more severe cases. Management remains largely supportive, but new therapies continue to be tested and are found use in at-risk populations. Vaccination is important to reduce spread and severity of illness. Vaccination is also key to reducing emergence of new variants and achieving herd immunity. The higher the vaccination coverage, including among children, the closer we get to that goal. All children's clinics and interventions to respond to MOH COVID guidance. That is the end of my bit of the presentation. We'll take questions and comments.
Thank you so much, Dr. Kalima. This has been a very, very interesting presentation, an exciting one. I know it was loaded, the network, I know you're overwhelmed, talked about the management of patients, and then now we talk about the vaccinations in children. But I think you will appreciate that it was a worthwhile presentation to have. So before we go on, I wanted us to just do the poll questions so that we can just clear off some of that. So we'll relaunch the first poll question. Sorry. So maybe network, we can quickly just respond to that one. Having discussed this, what do you think is the answer here? Is it all of the above, or we still have any that think otherwise? Maybe we can just poll. I've seen some comments. We're looking for poll questions. We're looking for the presentation. This will be shared on Slack and on the various WhatsApp platforms. I hope those who receive can share with their colleagues. Okay. So there's some questions I've noticed. We'll read the questions a little later. So I'll end the poll. Dr. Nawa, here, you want to make a comment on the poll, the first poll question? Most
Sorry.
people now, maybe a
So,
comment.
yeah, at least I think I'm quite happy that most people now see that all of the above are actually correct, though fewer people polled for this second question than the previous round. So all the above are correct based on our presentation. There's equal sex. Yeah.
Thank you so much. So the next poll question was another interesting one. We invite the network to just poll. Which one is not correct here? I see some very interesting questions in the chat. We will be able to respond to them in a moment. We will respond to them in a moment. So we have been privileged and we've been joined by a panel of experts. I'll just run through them again. We have Dr. Chelo Mwinga, the Senior Registrar on the Children's Hospital, and in the COVID ward. We have Dr. Zachary. We also have Dr. Manoj Matthew, the Head Clinical Care, Children's Hospital. We have Dr. Bobo, the Assistant Director, Public Health, Child Health. And then we have got also other experts. Thank you very much for joining us. And we really appreciate the presence. So I will share the results. So most people think that D is correct. Would you like to make a comment on that one, Dr. Nawa?
That is actually the case. So MISC is a very rare complication among children, but it is a severe complication that we must avoid. We don't want to make it more common by allowing more infections among children. I'm just concerned that only 9 people polled for the second question.
Okay, that is fine. Okay, thank you so much, Dr. Nawa. I think we'll just give a few minutes of just some responses to some of the questions that have been posted before we allow Dr. Chilufya to come and just run us through some questions. So there's some questions in the chat box. There's some questions here. I'll just try and briefly read some of them. There is a concern here saying, sorry, I missed it. Do we have local data on the epidemiology of COVID-19 in children so far? That's one of the questions. And then the Nentola asks, question 1, can we predict the vaccine safety of children based on level 3 studies reports? Question 2, do we have any African-based competing studies which assessed safety of the vaccine in children? And then so that we can make comparisons. So any role of monoclonal antibodies in children. So I'll invite any of our panel experts that can pick up this particular questions. You can just raise your hand and then we can respond to these questions quickly. Okay, so I'll ask, perhaps I can ask maybe specifically, I don't know, Dr. Bobo, would you like to make a comment on the vaccine safety of children, level 3 reports? And we have any African-based competing studies on this one? Maybe Dr. Bobo, you can respond to that.
Thank you very much. Sorry, I was just changing the address. Thank you very much, Dr. Kozia. So I'm not aware of any such studies within Africa, unfortunately. And remember, for Zambia, we've just started. So we do not have enough data as it is. What we are depending on is what we get from the West. And I must add that Pfizer has actually been, it's the first vaccine that is being administered to children the reason being that it was the first one to be actually put on the emergency use list of both the WHO and the FDA. And it has been in use for the longest, and there's a lot of data. So based on that, we've also made recommendations, and that's why we're using it. And the other thing I wanted to comment on is the fact that I was actually looking for a slide which I can't find. In terms of the numbers, I think ZNPHI recently showed that they haven't seen any significant changes in terms of numbers of children who have been infected when they look at the data they have for the various waves that we've had. It's just that I can't find the slide. I thought it was going to be very important. It was going to be interesting to see that as well. Thank you, Dr. Zambo.
Thank you so much for those responses, Dr. Bobo. And then perhaps I could ask Dr. Matthew maybe to make a comment as well on is there a need for routine testing for newborns? Newborns born to mothers tested for COVID?
Thank you so much, Dr. Ziamba, and a very good afternoon to you all. There is no role, and especially that we're currently at a level where we've been 20 to 35% positivity, and in a resource-limited setting where we need to secure our commodities, there is no role, and it's really be streamlined towards patients with clear clinical picture and high index of suspicion. So there's no role. This applies to even outpatient services. We've been saddened over the past few months where even patients who are asymptomatic coming to outpatient clinics, either the ART clinic or if a TB follow-up or a DM patient or a CP child being requested to be tested before they're seen in the outpatient services. So there's no role. And even those who come to the outpatient, we need to streamline and guide on who should have these tests done. So maybe I'll take advantage just to respond to a few more things that were queried on the data collection and local data. There's currently some work that is being done with our colleagues in a few sites, and this is unpublished data, but just to indicate that in the second wave, we had quite a number of children on the older side between 5 to 15 DM sickle cell, but in this particular wave, we've seen a broader range, of patients presenting with a few sickle cell patients, but not as many DM patients. And we're hoping that with some of the, a few things that we put in place, we'll be able to share some of this data later on. And then maybe also respond to the issue of, or I think Dr. Bobo had actually discussed that one, on the issue of the vaccine safety. I think ultimately, like was indicated by Dr. Kalima, the benefits outweigh the risks. And the more we get the broader population, especially now that we are reopening the schools in the next couple of weeks, and we've had more children that have been affected. So we're hoping that this drive will not just be for the 12 to 18-year-olds, and Dr. Bobo, I'm sure, will guide us soon when we'll be able to bring that number, age range, to below 12 years, so 5 to 12. Thank you so much, Dr. Ziambo.
Thank you so much, Dr. Matthew. Dr. Nawa, I've seen you raised your hand. You could unmute and respond. You could also talk about the use of antibiotics. There's a question here where they're saying, when do we use antibiotics? Thanks.
Is it antibiotics or monoclonal antibodies? Which one is it?
So there's one on antibiotics, and then what's the role of monoclonal antibodies?
Okay. All right. Okay. First off, I just wanted to add to or respond to Dr. Ntula's. I know Dr. Bobo did mention there are not many studies in Africa. A lot of the studies on vaccines were carried out in the West. There were a few sites. I know South Africa was a site for Johnson & Johnson trials. There has been reports of Sinovac being tested in some children in South Africa as well as part of their trials. So we are yet to get actual reports on, or initial reports on how that is going. But they did initiate some trials in South Africa. But other than that, Africa has been quite behind in terms of involvement in vaccine development and testing. And then in terms of antibiotics, generally antibiotics are only indicated in patients for whom we are able to or strongly suspect a comorbid bacterial infection. We have talked about scenarios where we're dealing with suspected comorbid community-acquired pneumonia, for which penicillins would be the best approach. And then hospital-acquired pneumonias, where you can think of cephalosporins. There are other situations such as patients who develop sepsis or septicemia, where we may give empirical antibiotics, but this, like we said, is on a case-by-case basis. In most cases, care is supportive. Antibiotics are usually the last resort for mild to moderate cases.
All right, thank you very much, Dr. Nawa. Dr. Zimba, I've seen you raise your hand. Go ahead and make a comment.
Thank you, Dr. Ziambo. So I think I wanted just maybe clarification from Dr. Matthew, because we do have policy for a number of facilities having targets on the number of patients that they need. Hello, Dr. Ziambo. So I was asking a question to Dr. Matthews, I think just a follow-up to the comment he had made about not testing everyone that comes to a facility. So I think the genesis of testing everyone is based on the targets that facilities are given. So you find, for instance, in Lusaka sub-districts have the target of testing about 600 or so, somewhere there, patients per day. So as the policy guidance changed, that they only test symptomatic patients for now.
Thank you. Dr. Ziambo, I can respond to that?
Please go ahead.
Thank you so much, Dr. Zimba. Yes, there has, and basically it's driven by the community spread currently, and for asymptomatic patients, these are patients who are asymptomatic, just coming to an outpatient for a review and for a pickup of meds, and also to secure our commodities. We're running out of those test kits, but more importantly, for the asymptomatic, there is no raw, and that's the guidance. Let me just add on also to what Dr. Kalima was taking, maybe to just reinforce the conversation on the monoclonal antibodies. We do have access to this, and these have been generally provided to the adult population. There's some risk stratification for children above the age of 12, so those with comorbidities, And I know we haven't used those in our children's hospital thus far, but I'm aware of a few patients in a few private facilities who were referred and were consulted on, who had access. And these were patients who had asthmatic, some comorbidities, and came in with moderate, mild to moderate and some moderate to severe picture. Thank you, Dr. Ziambo.
Thank you so much. I think we can ask so many questions, but I think for now, allow me to hear from Children's Hospital as they share one of the cases that they are currently managing at Children's Hospital. So, and I'll allow Dr. Chilusia to come on and just share this presentation today. You can introduce yourself.
Good afternoon, everyone that's on the call. I'm Dr. Chilusia Rose. I'm registrar pediatrics currently attached to the COVID ward, SAR L5. So I'll be running you through our case, a patient that we're managing in the COVID ward currently, and we'll have a discussion after the summary of the patient. The patient is still an 11-year-old female born on the 23rd of May, 2010. She came to our hospital on the 2nd of January, 2022. And she initially presented with a 4 days history of generalized body pains and a day history of fever. She is a known patient to our hospital whom we've been following up for sickle cell anemia. So in addition, she also presented with complaints of backache and left leg pain. She had also a day history of difficulty breathing, which mom described as fast breathing, fast respirations, but no history of cough or flu symptoms, and she had no chest pain. Then she had no GI symptoms and no signs of failure when she presented. On initial assessment, she was fully conscious. At the time she was seen, she was on O2 via nasopharynx at 2 liters per minute. She was in pain and had mild subcostal recessions, was pale and jaundice, mildly jaundiced. She was not diagnosed. Systemic exam, the chest CBS was normal, and she had no, the abdominal exam was normal. So on initial presentation, our initial diagnosis was SARS-CoV-2 pneumonia in non-sickle cell anemia patient in VOC. And she was managed, as we can see. So investigations that were ordered on first presentation was a full blood count, ESR, biochemistry, and a chest X-ray. So she was in terms of management. She was started on oxygen therapy, received adequate pain management with morphine, paracetamol, and diclofenac. She received IV fluid therapy, was then transfused with packed cells, and on initial presentation was started on azithromycin. So these are the investigations that we had.
Sorry to interrupt. Are the slides moving? They're not moving on our end.
They're not moving?
No, have you put it in presenter mode?
It is in presenter mode.
Okay, maybe, I don't know.
Okay.
Let's just work on that and get back to you.
Are we able to see the slides now?
Yes, yes.
All right. So I gave a brief summary of this slide. If we're not clear, we can ask later and then I'll clarify. But on initial assessment, as I said, she had a normal systemic exam, that she was fully conscious on O2, was in pain and had mild subcostal recessions. She was mildly pale and mildly jaundiced, and she was saturating at 93% on room air. Our initial diagnosis, as I earlier said, was SARS-CoV-2 pneumonia in a non-sickle cell anemia patient in VOC. And then what was done for the patient? So on initial presentation, a full blood count was ordered, ESR, biochemistry, and chest X-ray. She received oxygen therapy, adequate pain management with morphine, paracetamol, and diclofenac. She was initially started on azithromycin and received IV fluids and was later on transfused with BAC cells. And the investigation results. So prior to the blood transfusion, on the day that she presented, that was a full blood count. So white cell count was in normal range, 6.82. Red cell count was low, 2.31. Hemoglobin was 6.4. Platelet was 419, which was normal. Neutrophils were in the normal range, 3.72. Lymphocytes, 1.72, which was normal. And so were the monocytes. The ESR was 1 millimeters per liter. Renal function tests were normal. The liver function test, ALT was normal, and AST was slightly elevated. So post-BT, that's the picture that we had after she had received a blood transfusion. Her HB increased to 8.3, her platelet count was 789, and her white cell count was 9.11. This was the X-ray, and so as with regards to the X-ray, we can see that it was not well aligned. The patient had rotated, but we could see that when you look at the lung fields, she has bilateral heterogeneous opacities more on the left, and it could be the rotation, but there is an obvious cardiomegaly when you look at that. We need to note that the patient was not well positioned. So on follow-up physical examination findings up to now. So far, despite having a history of fever on presentation, the patient has remained pyrexic while on the ward, and her respiratory rate has ranged from 14 to 30, pulse rate 68 to 120. So these high readings are the readings that we noticed initially, I think on the second day of admission towards the third day in the hospital, but have since stabilized, as we'll see. Saturation, sorry, 042. So she would desaturate to as low as 83%, but we should have indicated that her baseline saturations 042 have been between 89, sorry, about 93. And on O2, via nasal probes, she's been saturating at 98 to 100%. So follow-up examination, this is a patient who's aware, alert, she's oriented in time, place, and person, currently not in respiratory distress, still mildly pale, has a tinge of jaundice, and has stable respirations, and cardiovascular exam, she has good volume pulses with a pulse rate of about 83 beats per minute. Then our current management plan is that she's on dexamethasone. So it is worth noting that this patient, initially when she came, she was in VOC. It started resolving, but she's had days where she wakes up and she has complaints of backache, and today was one of the days. And so she was started on intravenous fluids, and we'll still continue with analgesia, and she's on oxygen therapy currently. So our plan also is to source for hydroxyurea. So we'll put it there. She hasn't started receiving the hydroxyurea, but our plan is to source for hydroxyurea as for this patient, as mom is not able to afford. And we're planning to repeat the COVID-19 PCR swab tomorrow. So the final outcome of the patient, so as earlier mentioned, she's still in the COVID ward, and we're managing for VOC, and currently on oxygen therapy at 5 inches per minute via nasal cannula. And generally, she's, despite having low saturation, she's a patient who's stable. So from this case, our questions then, what is the role of antiviral therapies such as remdesivir in children with COVID-19? When are corticosteroids such as dexamethasone indicated in children with COVID-19 with comorbidities such as sickle cell disease? And how can we optimize the care of these patients?
Right, thank you very much for the case presentation, and we invite for any clarifications that the network might have. If you want any clarifications, then we can make those clarifications. I've seen some hands. Yes, Dr. Ngwenya.
Hello, good afternoon, Dr. Ziambo, and good afternoon, everyone. I just had a few questions. I noticed you did the ESR as opposed to CRP. Probably you could clarify on that one. And I just wanted to find out whether D-dimers were done for this patient. And then the other thing is in terms of IV fluids, I know in terms of sickle cell disease and COVID-19, aggressive hydration may actually precipitate lung injury. So I just wanted to find out whether you made any adjustments to the usual protocol in terms of hydration. Thank you.
Thank you. Any CRP, D-dimers, and ESR was done instead of what were the challenges?
Okay, so the challenges with this patient is that when we had discussed with the lab last week, that we were informed that they're unable to do a therapy. D-dimers were ordered. Unfortunately, the sample was not run, but we had a discussion with the lab this morning, and they've assured us that today they'll be able to do D-dimers. So we have resubmitted samples for D-dimers. Then in terms of hydration, we're not aggressively treating, giving IV fluids the way we give patients in VOC, where you multiply the maintenance by 1.5. We're just giving her maintenance IV fluids as of now.
All right, thank you very much. Doctor, I've seen another hand. Sorry, I'll call you on you later, Dr. Kalima. There's a Chiwuyu from Rural Health Center. You have got a hand raised. Would you like to unmute and ask your question?
Okay, thank you very much, Dr. Kozia and the presenter. The case is quite interesting. What we just wanted to find out as Chiwuyu Rural Health Center was, we noticed that the platelets are quite high for after transfusion. Isn't there a risk of clotting or even possibly a stroke in this particular patient, looking at the initial platelets were at 4 something and then it went to 780 something. Thank you.
Take a note of that question. Yeah, I can respond.
As we know, in patients that have sickle cell disease, they tend to have, I understand that initially you have platelet count was 419, but typically patients with sickle cell disease, they tend to have a thrombocytopenia, thrombocytosis rather. So in this patient, the thing is, so as you can see, the first full black count was done on the 2nd, and the repeat was, those results are for the 8th. So we unfortunately do not have any readings in between. So I personally wouldn't worry of a stroke in this patient, just for the fact that the patients with sickle cell disease tend to have a thrombocytopenia.
All right, thank you very much. So I think for the sake of just trying to respond to this, I think maybe we can have any comments on this. I'll invite the network if they've got any comments they would like to make regarding these questions that have been raised by the units. The unit I know is being managed competently by our pediatricians here, but I think we brought this up just for discussion's sake, so that as we continue to manage these patients, we can understand how we can intervene in terms of the various aspects of treatment. So maybe we can get 1 or 2 comments from the rest of the network. Dr. Nawa, you wanted to make a comment? I see your hand is up.
Okay, so just maybe 3 comments. On the X-ray, you mentioned the cardiomegaly. I get excited when I hear such things. It's actually an X-ray taken in AP view, if I'm not mistaken. So it does tend to make the heart look bigger than it should. Another thing is I was hoping you would mention to the house that there's zithromycin in this case was because this was a sickle cell patient, and we know the types of infections they are at risk of. particularly when it comes to respiratory infections. Otherwise, we don't advocate for the use of azithromycin in COVID. Somebody asked any role for baricitinib in children. I think the jury is still out even in terms of baricitinib in adults, and in particular with this new variant of COVID, which is almost every patient that's testing positive is Omicron positive. So a lot of monoclonal antibodies and interleukin-6 inhibitors are still being tested on the Omicron variant. So really, I think we can't say there is a role for these drugs before the evidence is out. I submit.
Thank you so much. Thank you so much for that comment. Any input from our panel experts so far on how we can when we can use remdesivir, particularly in children, and at what point do we think we can introduce corticosteroids, and how we can see how we can optimize therapy treatment in this patient. Dr. Mwinga?
Thank you, Dr. Ziambo. Can you hear me?
We can hear you loud and clear.
All right. Thank you, Dr. Kalima, for clarifying. I was a bit worried that maybe the fact that we're using azithromycin there was lost in translation, especially that it wasn't mentioned amongst the patients you had pointed out that needed antibiotic treatment. One of the reasons I think this particular case was picked up was to point the fact that it's very important that each patient is looked at individually. And we have had quite a high traffic of patients coming in with sickle cell during this particular wave and the wave before that. And studies have shown actually that, I mean, it goes without saying that sickle cell disease patients are at higher risk of hospitalization and development of pneumonia, as well as in developing VOCs when infected with COVID-19, and they are likely to be more at a high risk of the disease then becoming fatal. So our patient initially came in with mild symptoms of COVID-19. What I wanted to point out here is that for non-critically ill sickle cell patients with COVID-19 infection, dexamethasone can actually limit progression to severe disease. And anecdotally, we've found that the patients that come in who we treat, who need oxygen, and we start initially on dexamethasone, we give them a blood transfusion, and we treat them as we would normally treat a patient coming in with acute chest syndrome. They actually have a shorter duration of stay than those who we don't treat in a similar manner. So the issue with acute chest syndrome, as you know, it's very difficult sometimes to diagnose. So in cases where you have a patient who's recurrently hypoxic, blood transfusions actually do improve the rate of recovery. You find that even within 48 hours of having given a patient a blood transfusion, they tend to respond better. So I would say for your question number 2, that dexamethasone is good in patients with sickle cell disease, especially when they come in with overt respiratory symptoms such as hypoxia or difficulties in breathing. Thank you, Dr. Ziambo.
Very, very valuable comments coming in there from Dr. Mwinga. We appreciate. Thank you so much. Any other comments from the other experts on how we can optimize the care for this patient? Dr. Ngwenya, would you like to make a comment on this?
Yes, thank you. So I had just wanted to comment particularly on the analgesia. we remember that early on in the pandemic, there was concern that NSAIDs might exacerbate the symptoms in patients with COVID. But then we actually need to treat patients in terms of vaccine variants and basis. This is a patient with sickle cell disease, and we know patients in VOCs really are in excruciating pain. So we really need to follow the step ladder approach very well. So in terms of use and optimizing care, this is one patient we would still go ahead and use a non-steroidal anti-inflammatories, because then we know that the benefits for this particular patient outweigh any risk theoretically placed in literature. That's one comment I would put across. Then the other one is actually in a question form. Certain data does indicate that the use of hydroxyurea, which is a cytotoxic agent with immune compromising effect, may actually in some cases increase morbidity and mortality. So I had just wanted a comment on the use of hydroxyurea in patients with sickle cell with COVID. Thank you. I submit.
Thank you very much for those comments. Thank you so much. And if there's a comment in the chat there, there's saying, would the patient benefit from prophylactic therapy of anti-thrombotic therapy? And I think from the team's management plan, I think that's where they're probably headed, because they will be getting some kind of results on the D-dimers, so that we can risk stratify this particular patient with evidence. And so I think with that, we hope that patient care might be optimized of some antithrombotic agents to help in the management of this patient. Any other comments from the panel or anybody on the network as we conclude on this particular case here?
I think the question on remdesivir hasn't completely been addressed.
Please go ahead, Dr. Nawa.
Yes, so there is a role for remdesivir in children, mostly restricted to children with severe disease. And more recent studies have shown that overall side effects are quite low in children. So there is a role actually for remdesivir. I think with the upcoming COVID guidelines, you will see the guidance on the use of remdesivir in children, mostly for severe infections or severe COVID.
Thank you very much. Dr. Cello?
Yes. I actually raised my hand for something different, but just to follow up Dr. Nawa's point on remdesivir, actually, in patients with sickle cell, they have indicated that there's a role in those patients who cannot receive dexamethasone for one reason or another. So I got excited actually when Dr. Ngwenya, it's Ngwenya, right? Yes, mentioned hydroxyurea. So the problem with hydroxyurea is that the different studies say different things. For instance, with the American Society of Hematology has actually pointed out that for non-critically ill sickle cell patients with COVID-19, if they have other pre-existing illnesses such as cardiopulmonary illness, renal illness, stroke, or are not receiving hydroxyurea, it has been found that actually they have a worse disease progression than those children receiving hydroxyurea. There are other papers actually which contradict each other. One advocates the use of hydroxyurea in patients, especially sickle cell patients, in this time when we are actually having this pandemic. So if the chair, Dr. Ziambo, would allow me, I would really love to have this conversation outside this particular fora with Dr. Ngwenya.
I was actually going to say that
yes,
it's getting complicated.
So that so that maybe we can discuss and sort of come up with a solid guideline as to whether hydroxyurea can be used or not.
Yeah, so actually hydroxyurea has got a lot of work around it, both in a lot of places. So, and it I think at this stage it's used mostly case by case. As you see the need case by case, and so I think we'll pick it up on another time. But I think for now, perhaps we could just be more on the things that we have a lot of evidence on and a lot of support around that. Thank you so much for your comment. We are almost coming to the close of today, and I do hope that we have had some fairly good discussions around the management of COVID-19 in children, particularly with certain comorbidities. And I think for those of some of our colleagues in different places where we do not manage some of these things, I think for us, the takeaway points is to just have an idea on how we can approach some of these patients when they come in our sites. So when we have a patient with a comorbid condition, I think this is some of the where we can think about them, quickly do the ABCs, and then we quickly refer them for further management at an institution with the expertise. Thank you so much, everybody, for connecting and being active participants in this session. I've just seen a comment here. Remdesivir is an antiviral which binds to the viral RNA molecule and inhibit viral replication by terminating that transcription prematurely. Very good drug to be used in COVID management. Definitely, remdesivir has received a lot of thumbs up in quite a number of studies, and it has shown to actually be very helpful. And there's one study that was released recently that actually showed and was used in mild cases, and it showed reduced duration of symptoms. And so I think we're still really seeing a lot of work being done around COVID. Remember that it's a new disease, 2 years old, and a lot of information evolving, and so just continue to learn. So I think with that said, I just want to thank Dr. Nawa Kalima for the way that you've delivered this session. I think it's been very, very enlightening and informative. I want to thank Dr. Natasha Ngwenya from Levis. Thank you for joining us. Your input has been valuable. Dr. Chelo Mwinga, thank you for joining us. Dr. Matthew, Dr. Bobo, we thank you for joining us on this call. I think I also want to thank my colleague here in the hub, Dr. Sylvia Rose. Thank you very much. She worked over the weekend just to put this together. Please give her a thumbs up. Thank you very much. And so we've come to the end of the session. I just want to maybe give an announcement that next week we are resuming our series, our HIV/TB Echo. And we will start off the HIV/TB Echo with a presentation from the HIV program. Our Director of Infectious Diseases, Professor Lloyd Mlenga, is scheduled to be the one to make the presentation, just to give a start to how we're going to move in this year, particularly for the HIV/TB program. And then from there, we will pick it up and we'll share our upcoming interesting sessions on ECHO. I think that being said, thank you very much, everybody, for joining. And I don't know if Dr. Kalima, you want to make your final comments, take away on this particular presentation.
I think you've preempted everything. We hope for a lot of good things this coming year. Hopefully we'll we'll have a good year. Hopefully, we'll have better coverage in terms of vaccinations, and we can get closer to eliminating this virus.
Thank you very much. We've come to the end of the session. I'll see you next.